A 22-year-old woman, G1P0, comes to the emergency department because of severe nausea, vomiting, and vaginal bleeding for the past 2 days. She is 11 weeks pregnant by last menstrual period. She has had difficulty keeping down foods or fluids and feels lightheaded when standing. Vital signs show blood pressure of 160 over 100 millimeters mercury and a heart rate of 104 per minute. Physical examination reveals a uterus that was larger than expected for gestational age. A transvaginal ultrasound reveals an enlarged uterus with a heterogeneous intrauterine mass containing multiple anechoic spaces and no fetal pole. Which of the following cells is responsible for secreting the hormone that should be measured in this patient? Choice A, theca cells. Choice B, granulosa cells. Choice C, luteal cells. Choice D, syncytiotrophoblaст cells. Choice E, cytotrophoblast cells. Or choice F, decidual cells. I'll wait 5 seconds and answer the question. Alright, so I'm going to try to keep this short and simple. This is a very straightforward diagnosis of a molar pregnancy. In this case, most likely a complete hydatidiform mole, which is to say it was formed from a blighted ovum being fertilized by either one sperm that then divided or 2 sperm at the same time. Most of them are 46XX. And we know it's a complete mole and not a partial mole because the symptoms are very severe nausea, vomiting, vaginal bleeding. If you want to get fancy, it's called hyperemesis gravidarum, and it's further supported by the transvaginal ultrasound, where we see heterogeneous intrauterine mass with multiple anechoic spaces, which is basically the cysts, with no fetal pole, so there's no fetal parts, essentially, at least that we can detect. And these are features of a complete mole versus a partial mole, which has more mild symptoms and would have fetal parts in the mole, typically. So the symptoms, like the nausea and vomiting, comes from the fact that the trophoblastic cells tend to grow uncontrollably in a molar pregnancy, and they release high amounts of beta-HCG. So most relevantly, we would talk about the syncytiotrophoblaст cells, right? So choice D is the correct answer. So usually in a molar pregnancy, you often test beta-HCG and it'll be very high. And of course, it's much higher in a complete mole versus a partial mole, which leads to the more severe symptoms. Beta-HCG is also responsible for a lot of the nausea in a normal pregnancy. So you can think of it as almost like that turned up to 11 in a molar pregnancy because they have so much beta-HCG. Only other thing worth noting is that molar pregnancies are typically considered pre-malignant and they increase the risk of choriocarcinoma. So looking at the wrong answer choices here, let's talk about both A and B at the same time. We have theca cells and granulosa cells. I've already talked about this in other videos. Theca and granulosa cells are very high yield. You need to know what they do. LH stimulates theca cells to produce androgens, and FSH stimulates granulosa cells to aromatize androgens into estrogens. So when you have a condition like, say, polycystic ovarian syndrome, and you have very high LH and low FSH, theca cells get stimulated to produce a bunch of androgens, and that leads to symptoms of hirsutism and whatnot. And because the granulosa cell and the follicles are not being stimulated, you'll end up not having ovulation. They'll become cystic formations, and later on you still end up having an excess of estrogens as well. And that leads to unopposed estrogen, which can lead to endometrial overgrowth, which increases the odds of endometrial cancer in patients with things like polycystic ovarian syndrome. Very important for you to know LH, FSH, how they relate to theca granulosa cells. But they're not relevant here because they do not secrete beta-HCG. Wrong answers. Choice C, luteal cells. So after ovulation, the theca and granulosa cells will differentiate into cells of the corpus luteum. They will secrete progesterone until the placenta is able to take over if a viable pregnancy happens. Corpus luteum itself is maintained by beta-HCG, but it does not produce it. Choice E, cytotrophoblast cells. The cytotrophoblastic layer is the inner trophoblastic layer, and they're basically precursors to syncytiotrophoblaст cells, and they themselves do not secrete beta-HCG. Cytotrophoblast cells are also largely irrelevant on USMLE. I don't think I've ever seen them test on them. Not that important to know. Choice F, decidual cells. This is referring to, I guess, endometrial stromal cells. They're influenced by progesterone, and they grow and differentiate and support the implantation of a fertilized ovum. And once again, beta-HCG is not really involved here. So once again, molar pregnancies, you got complete, which is a blighted ovum being fertilized by one sperm that then divides, or two sperm, usually 46XX, usually more severe symptoms, and you'll see a bunch of cysts in the uterus, no fetal parts. Partial mole is when you have a normal ovum and it's fertilized by two sperm, and it's often 69 chromosomes. It can be XXX, XXY, or XYY. It varies. The symptoms in the mother will be more mild. You will also have an overgrowth of syncytial trophoblast cells, which causes cystic formation, and oftentimes there will also be fetal parts in this unviable pregnancy. And of course, oftentimes for both of these, you can test beta-HCG and it'll be very, very high, and it's what causes a lot of the symptoms in a molar pregnancy. I hope this video was helpful. I'll see you in the next one.